All right, I think we can get started. Hi, everyone. Thank you so much for joining us. My name is Kirsten Stumpa. I'm a clinical application specialist for the Lenstar by Haag-Streit. And joining me today is Carrie Menard. She's also a CAS, and she's going to be assisting me today by watching the chat box. So feel free to type in your questions as we go. And we're going to do our best to make sure we address all of your questions by the end of this session. Today's Surgeon and Advanced Technician webinar will be a total of about an hour. I'm going to start by reviewing the cautions that you sometimes see as a result of Lenstar measurements. And then I'm going to be going over why these cautions appear. I'm going to touch on the dense cataract mode and how to enter a new lens, and also some calculation features in our latest software. Our latest software version is i9.3.1.0, and if you're unsure what software version you're currently running on, you can simply click on the question mark in the toolbar, choose About iSuite, and in bold print, you'll find the version of software that you are actually running on. I'm also going to be throwing in some interesting measurements as we go along throughout the session, and we're going to get started. In the iSuite software, various cautions are used to bring our attention to questionable measurement results, and these cautions do not always mean bad measurements. Now, we should be watching out for axial length and Ks, the most important measurements, and we're going to validate those by looking at the standard deviation. So the acceptable standard deviation for axial length should always be under 0.1 millimeter, Ks under 1/4 diopter. And if we have enough astigmatism to qualify a patient for a toric lens, we want to make sure that the axis has a standard deviation of less than 3.5 degrees. Now, if you're plugging in your Lenstar measurements into a third-party LRI calculator, probably want to address axis for that as well. Any other measurement will be automatically assigned a caution in the iSuite software. A triangular caution has different meanings you're going to find out today. And a circular caution always indicates a significant difference between the two eyes. Just keep in mind that one single Lenstar scan actually involves so many measurements. In fact, one biometry scan of the eye reflects off of the retinal pigment epithelium 16 times. So over the course of 5 scans, that's 80 reflections used for an overall average that will ultimately be used in the various formulas to calculate a lens power. Now, as you know, Lenstar is an optical biometer. It uses optical low coherence reflectometry and an 820 nanometer superluminescent diode laser, which is a fancy way of saying we're projecting a light into the eye and it's bouncing off the reflective surfaces. So if you notice in this brief PowerPoint, the laser enters the eye and bounces off of the epithelium of the cornea, including tear film, and it bounces off of the endothelium of the cornea. Then it travels through the aqueous and bounces off of the anterior lens capsule, followed by some noise from the front of the nucleus, varying levels of noise inside that lens, the back of the nucleus, and then the posterior lens capsule. Then it travels through the vitreous and it bounces off of the inner limiting membrane and the retinal pigment epithelium. Now, the iSuite software is programmed to land these gates on average spikes. So if you notice, this gate, the first gate to the second gate, is giving us our average central corneal thickness. The second gate to the third gate is giving us our average aqueous depth. The third to the fourth, our average axial length, and the very first gate to the very last gate, our average axial length. Now, let's look at an example in iSuite on a measurement. All right, so this measurement we're going to refer to is actually a saved measurement. Now you're going to notice in your software that you have 2 biometry icons. One is for a new measurement, and you'll find another one under examinations with a date stamp for saved measurements. Now keep in mind the plus sign next to the date stamp does reveal additional items done in the same day, and they will be time stamped. So just double click to open a scan, and we're going to quickly find that a caution here next to lens thickness I'm sorry. If we hover over it, it tells us that this value has a high standard deviation. Please check for outliers. So we can click on any of these values to present that A scan that we saw in that brief PowerPoint animation. Now, an interesting way to look at this is how it happened in chronological order. So I'm actually going to remove all of the scan except for the very first scan that we took. So this is the first scan taken by the Lenstar, represented in red. Now watch these gates as I add the additional scans in, and pay close attention to this gate here. So here's number 2, 3, 4, and 5. Notice how this gate moves the most, and we can pick up on the variability here in each measurement. Since the lens thickness is cautioned, this will be the gate that we need to address, and in order to do so, we recommend using a zoom scan feature. Notice my cursor is a plus sign throughout the graph until I click on the zoom scan, which is a graph with a little magnifying glass in the upper right-hand corner. And when I click the zoom scan to activate my highlighter, my cursor actually changes to a double-headed arrow. And if you notice, there are hash marks in the X and Y graph, which allows me to find a nice center medium here in the aqueous depth. Then I'll click and hold and drag a highlighter past the last lens spike in question, and when I release, I'm zoomed in on just the lens thickness spikes. Now this gate found it very easy to land on this first spike of multiple colors. We measured that surface every single time. However, we pick up on variability here, and we notice that we have a couple colors actually representing the posterior lens capsule. But we can fix that by matching our cross or our plus of our cursor up with the plus on the gate until we get a 4-headed arrow. And then when we click, hold, and drag, we can move the gate out of the way using our line to dissect the very last spike of multiple colors, and a mouse click release to drop it on the peak. Now we have a finger pointing down over the icon that was moved, and our measurement value changed. We can fit this scan back to window, we can print it out, review it with a colleague or a surgeon. However, if you're still questioning this gate position, it is always good to drag it to the side so that we can use bilateral measurement comparisons. This is very important and very helpful when we're trying to validate and fix a caution when we have a bilateral measurement to compare. Notice the right eye is cautioned in the original scan, and it read a 4.0 millimeter lens thickness. However, the left eye was not cautioned, and it read a 4.2 millimeter thickness. However, if you note, before I click to save, our new lens position now reads a 4.2 millimeter lens thickness, and is very agreeable with our fellow eye. So it makes sense, doesn't it? So when we click OK to save, it replaces the caution with a single asterisk, meaning the value was user-defined. Now, as you probably know, lens thickness is not used in all formulas, but it does actually improve the accuracy of the Barrett Universal 2 formula. So if you're relying on the Barrett formula, you really should be addressing lens thickness, especially when it doesn't agree with the fellow eye, and especially when it's cautioned. Now, extremely small measurements to the lens thickness, such as what I just did, does not change your calculation results dramatically. In fact, you may just notice a slight adjustment in your intended refraction. But depending on how much you have to adjust the lens thickness, you may notice a bigger shift in the recommended or in the intended refraction, or even the recommended lens power. And it's also depending on what you're aiming for. So it could make a difference of a half a diopter step, right? Now, what happens when you have a very dense lens? So when you have a very dense lens, during the measurement process, you are going to find no axial length will populate. But after the first 3 scans, so if you notice in this display, you have a axial length and it is highlighted, but this has actually not happened yet. So as the scan begins, no axial length is displayed, but Ks will appear. And over the first 3 scans, the same thing happens. And then after the 3rd scan, a composite axial length populates at the top. Additional scans done afterwards for the following scans will continue to build on this composite. and you will never have a standard deviation when a composite axial length alone. And when you get your measurement results, you will notice that an axial length without a standard deviation is likely due to the dense cataract mode kicking in. Now, keep in mind, light cannot pass through every material out there, so if you're attempting to measure a rock, you will likely need to use sound. However, the Lenstar does have this dense cataract mode, and it does kick in automatically. Just remember, it has to pass through that dense lens twice. So if there's a lot of disruption, the reflection coming back through that second time is very weak, and that indicates to the Lenstar to kick this dense cataract mode instead of displaying the axial length. So when you receive an axial length with no standard deviation, that's your first indication. And to validate the dense cataract mode, and I'd like to give credit to Dr. Warren Hill for this explanation, you can open your A scan. And here I have our A scan. And when you notice your dense cataract mode display, the retinal spikes are very spread out, such as this, you probably should do an ultrasound to confirm. Now, when your dense cataract mode, composite axial length retinal spike looks nice and uniform, such as this, you can have a lot more confidence in the dense cataract mode value. And in this case, we actually were able to scan a bit off axis and obtain a couple more axial length readings that agree with our composite. So if we double click those values, we can actually include those in an average and populate a standard deviation. Now keep in mind your ultrasound scan will always be shorter than your optical. Immersion will be the difference of a retinal thickness, so essentially an undisturbed cornea, and measuring to the inner limiting membrane. And contact A scan will be the difference of corneal indentation and retinal thickness. Therefore, optical will always have a longer axial length, measuring an untouched cornea and all the way to the retinal pigment epithelium. Let's go back to iSuite. I have some more interesting cases here. What happens when you cannot obtain an anterior chamber depth measurement or lens thickness? Well, let's see. If we try to go to a calculation, you will quickly notice that we are unable in the left eye here to obtain a Barrett Universal 2, a Hill RBF, an Olsen, or even a Haag calculation. But let's take a look and see what's going on with this measurement. Oh, sorry. So we're going to open up this A scan and take a look at the reflective surfaces here. Now first I'm going to bring your attention to a caution next to the central corneal thickness. This caution means the value has a high standard deviation, much like the lens thickness we saw earlier. Now there's two ways to resolve this caution. You can either remove an outlier and reduce the standard deviation, eliminating the caution, or you can simply pick up the gate and just validate that gate position. Now the next thing we're going to notice is every single aqueous depth measurement is eliminated. And this caution is actually meaning the value is outside of the allowed range that the software feels the measurement is valid. So it's finding this value to be erroneous. But if you look at our A scan, it's obviously picking up on the anterior surface of that lens. And if you notice, our axial length is only 18.23 millimeters. So obviously this patient has a shallow aqueous depth. And we can override this elimination by double clicking to include all these values into the overall average. And then this will populate a value. Now our lens thickness, we can again use our zoom scan and place that gate on the most posterior spike of the lens. And when we click OK, our cautions will remain, but again, those cautions mean the value is outside of the range. When we go to calculate, we will now be able to see a Barrett, a Hill, an Olsen, and a Haag. I have one of my most favorite examples. This patient was actually measured with ICL implants in both eyes, as well as the crystalline lens. So in lieu of having refractive surgery, she had ICLs implanted in both eyes. I fully expected to see cautions in the biometry, of course. So we're going to start with the left eye and take a look at the A scan. I'm going to use my zoom scan feature so I can take a look closer at these spikes. And with one red spike in the front here, I assumed that that would be the front of the ICL. So I decided to place the gate on the front, the very first spike of multiple colors, meaning we measured that surface many times, and the back surface here. Now, when I clicked OK, I decided to do a bilateral comparison, and I noticed the right eye had a lens thickness of almost 5.5 millimeters, which is very bizarre and much different than the left eye. So clicking to open this A scan revealed, by the way, we had no cautions. And when I zoom in on the lens thickness, this is a perfect example of an implant lens, very tall, very reflective surfaces, very thin and very clear, no noise in between. So it makes more sense to move this gate to the front surface of the lens. This is a textbook representation of a crystalline lens. Anterior lens capsule, beginning of some nucleus, some noise inside that nucleus, back of the nucleus, posterior lens capsule. So a nice side-by-side comparison of implant versus natural crystalline lens. Now, by moving these gates to better represent these values, we are offering these formulas that require phakic ACD and phakic lens thickness appropriate measurements. So when we click OK, we now have a new lens thickness, which is a little bit thinner than the left eye. So to open this and reevaluate based on what we saw in the fellow eye, let's zoom in on this lens again. Now we can actually measure surfaces here in the A scan. So when I place my gates on the front and back of what I consider the ICL implant now, it's reading about 1/4 millimeter thickness. And when I place my gates on the posterior lens capsule, there's the nucleus, and now the anterior lens capsule, and do another bilateral comparison, you will notice that our aqueous depth is much more similar and our ACD is actually exactly the same. So these values would be better values to use for those newer generation formulas that require that phakic ACD measurement and phakic lens thickness when we're taking Barrett into consideration. So let's talk about keratometry. So Lenstar keratometry measures with LED reflections off of the cornea, like many other autorefractors, but it's the dual zone pattern of these reflective points along with the spacing that's most beneficial. There's an inner ring of 16 data points at 1.65 millimeter diameter and an outer ring of 16 at 3.2. Unlike some of our competitors, this is actually extremely beneficial in getting accurate Ks, but also the right axis placement for your premium lens implants. So notice there's very little discrepancy between those meridians. As you know, keratometry is the second most important measurement used in every method of calculating out there. So first we want to pay close attention to the standard deviation. And secondly, we can review the images that we achieve during the measurement. So in this measurement, there are no cautions, but if we wanted to review the images, we certainly can. So we can click on any of these values, and it's going to display the data points. So each time we scan, we're obtaining up to 32 keratometry images 4 times for each scan. So that's the potential of 640 data points over the course of 5 scans. And anytime we're questioning, we can certainly open this display. And here's our first scan. Notice our second scan has cautions. Now in this first scan, we have nice bright data points indicating we had excellent tear film. And we have an evident visual axis reflection, meaning the patient was fixated. Now let's find out what this caution is about. It says uncertain measuring data. So when you click on exam number 2, you notice the patient blinked a couple of times. Software is programmed to identify missing data points and calls it uncertain data. But however, these 2 remaining scans, if you notice, the data points are nice and bright. indicating good tear film, and an evident visual axis reflection. So the average we're obtaining here in the second scan is based on 2 measurements alone. And if we reorder the K1 values, you notice this value falls in the center of all of these measurements, offering a nice low standard deviation. So is there any reason to delete? Not in this case. So if you're seeing a caution during a measurement and a single caution appears next to an average K, first check the standard deviation, and here's where we can identify if we need to delete or remove. Now let me show you an example of some poor keratometry reflections. This patient unfortunately had a scar or a pterygium coming up over the pupil in every single measurement. And you notice in this case, the caution means the measure was simply not usable because it's missing data points in every single image. Now, this patient would need to be measured in some other way, maybe manual Ks, to obtain the keratometry values. But when we go to calculate for this patient, we can input different Ks in the measurement data tab and move on to a calculation, still using all of our good biometry information. Another thing to watch out for is low-lying lids or lashes. So superiorly in all of these images, you will notice missing data points, shadowed data points due to the lashes and lids. And in this last scan, we notice even some lack of tear film, so some dryness. And this is all contributing to a high standard deviation. And when this is happening during the scan, it's advisable to allow the patient to take a quick blink and advise the patient to open their eye wide. And if they cannot keep their eye open, the cotton tip applicator technique, rolling the lid out of the way, is very useful with the Lenstar. It gets fingers out of the way, and it allows the technician to roll the lid for the scan, unroll to allow the patient to blink, and roll again for the next scan. Now, white to white measurements sometimes are cautioned, but I want to bring your attention to the fact that sometimes they aren't cautioned, but they should be questioned. Dr. Hill actually recommends questioning white to white when there is a difference of 0.2 millimeters between the 2 eyes. So this is an unusual white to white measurement, but we can question it by clicking on any of these values to open the white to white display. And what you'll typically find is if you have a very light iris, or maybe a scar or pterygium coming up over the iris and fading it out, these calipers are programmed in the software to find dark to dark surface. So if the iris is faded out, it doesn't know any better but to place itself on that dark area. But we can simply hover over one portion of this circle until we get the double-headed arrow, which tells us then we can move and drag that circle to a new position. So now we've identified that the white to white is actually 12.23 millimeters for that first scan. Now we just validated that based on a photographic image. So this value should be a good value to use for our formulas. However, if we eliminate all of the other measurements, we have a new caution indicating too few measurements result. So if you don't like seeing that caution, you do need to adjust 3 scans so that the software identifies an overall average based on 3 values. Pupillometry, now this is not cautioned, and if you do like to look at pupillometry, you can open up the pupillometry display to see why we're not getting any measurement values whatsoever. So by clicking on this area, we can open up the pupillometry, and you will notice this caution means the pupil not found. Verify the results. And this will happen anytime the pupil is very, very small, or in this case, irregular. So the computer is not sure where to place the calipers, but again, we can come in and adjust these calipers to best represent the pupil diameter, and then make sure it's included in the overall average. Again, we have a caution here simply because we have too few measurements. So if you don't like to see a caution on your results overview, you can adjust 3. Now, I also want to bring your attention to the X and Y. There's a dx and dy value for each one of these measurements. So I'm going to grab this first measurement here. And I want you to watch as I move the circle, the plus sign always stays in the center of that circle. So if I say this is the pupil diameter, this is assuming center of pupil. And the X and Y values are giving us an idea of the relationship between center of pupil versus visual axis. So if there's a large distance between these 2 points, we may want to consider disqualifying a patient for a multifocal lens implant, because if the patient ends up looking through a concentric rings, we will have poor outcome. Now, have you ever measured a patient with a dislocated IOL? Let's take a look at this example. This patient was measured on the basis of a pseudophakic acrylic setting because the patient had an implant present in the eye. Now, after a slit lamp examination, it was revealed that the whole capsule had slipped down about halfway through the pupil. So it was unsure whether or not the measurements from the Lenstar were based on aphakic or actually through that lens. However, there is a show image at the bottom of each measurement results for right and left eye. And when you click on show image, if you have a white light Lenstar, you can change the image to color by clicking on this red and yellow cyclic arrow. And when you change it to color, you can already see that capsule there. And if you click, hold, and drag a yellow square over the pupil, we're zoomed in on the pupil now, and the blue arrows will help you navigate through the various scans that were taken, or the images that were taken at the time of the scanning process. So if we scroll through these images, we will find that a majority of these scans, the visual axis was above the capsule. So based on this information, we can go back into the A scan, and here's our second opportunity to change our lens or our vitreous body. So in this case, we would want to choose none for no lens, taking out the lens and calling this eye aphakic. And when we click OK and OK to lose all changes, it will change our axial length from 25.02 millimeters to 25.13 millimeters, taking into consideration no lens and taking out the index of refraction of that acrylic lens. Another setting here, and this is a wonderful thing about the Lenstar, is you can change the vitreous body, and this is again after the patient has already left. So if the technician does not know or is not aware that there's oil in the vitreous, this setting can actually be chosen after the fact. And choosing that option and clicking OK to lose all changes will apply the index of refraction of the oil, which dramatically changes the actual axial length measurement because the oil is slowing down that light. Now, according to Dr. Warren Hill, if silicone oil is to remain in the eye for an extended period of time after cataract surgery, an additional adjustment to the IOL power must be made. He has some great information about this at on his website, and that website is www.dr-hill.com, and that doctor is spelled out, so DOCTOR-HILL.com. Now, once you're happy with your measurement results and there's no longer any review to be made, we're going to go and move on to a new calculation. Now, as you saw, saved calculations appear under examinations, but a new one will be obtained by clicking the IOL icon under the biometry for new. And in this screen, this is the measurement data screen, and this is a review of all the measurements which we're about to use for our formula calculations. So if you ever need to enter an axial length because it was unobtainable with the Lenstar, you can certainly type in a new value. It is completely fine to leave this as optical if you're using an immersion. Haag has said that there's not enough of a difference. However, if you're using an axial length obtained by contact A-scan, you do want to change this setting to acoustical. This will apply different formula constants that are applicable for contact A-scan axial lengths, which were always shorter. You can also modify, change, or add keratometry values if you don't agree or if you are unable to achieve keratometry. Then you'll move on to calculation. And here, of course, you have saved templates with an arrangement of lens and formula combinations. Now, anytime you want to make a change to these saved templates, you can certainly choose from different lenses and different formulas. And anytime you make a change, and you can also, delete cells or add new ones. Anytime you make a change to a template name, this box will appear as unsaved, so we're working with an unsaved template. In order to save our changes, we need to click the blue plus sign to create a new template from now this current configuration. Once we click the blue plus sign, we have two options. We can actually give this template a new name, or we can save this template as an original template name. We're just going to call this new. Now, when we click OK, it's going to add that template to this drop-down list, so you only ever need to modify templates in one eye. That template will also appear over here for the left eye. Now, if you cannot find the lens you're looking for in your lens database, you may need to add a lens. So in order to add a lens, you can click on IOL and IOL editor, or the shortcut key is this IOL icon. When you click to open your IOL editor, you will find that all of your lenses are arranged by manufacturer. And if we click the arrow next to any manufacturer, the subtitles are all the lenses made by that manufacturer. Again, if you can't find your lens in this database, you can simply click the blue plus sign above the list to create a new IOL. Now, when you start typing in the manufacturer name, if you are adding a new Alcon lens, you certainly want to choose from the drop-down list so that you're adding lenses under the same Alcon header. However, we're going to call this new manufacturer. And the model name will be the name that the manufacturer has given any certain lens. For example, SN60WF, but I'm going to call this one Sphere. Now, if you do not have the Toretti Planner option for your software, you will not have type spherical or toric. Nothing will display here, and it will assume that you're just going to add a spherical lens. However, if you have the Toretti Planner and you're entering a toric lens, choosing toric will allow you to add each model and the power at the IOL. And in the next screen, each model's cylinder correction ranges. We're going to keep this as spherical for now. You need to enter a row to this table to identify a range that the lens is available in and able to calculate. So by clicking the plus sign next to the available spherical powers to add a row, you can change these values to represent the powers that the lens actually comes in. So usually around 6 to 30 diopters at half diopter increments. You can add an additional range if the lens is 30 to 35 at 1 diopter increments and so on. But we recommend leaving it at -10 to 40 because you have more calculation options when you have really long or really short eyes to deal with. Then we're going to click on the calculation tab, and here's where we're going to enter our formula constants. Now, you will notice when we click this plus sign one time, it adds the manufacturer A constant. And it starts with manufacturer A, but when we keep clicking, we're going to go through all of the available formulas, and the last one we'll see is the Hill RDF A. Now, you will be able to obtain these values from your manufacturer on any new lens. The SRKT A constant is your optical A constant on the specification sheet. The Shamus No History always shares that same value. And we'll scroll up and find the Barrett LF. And there's actually a feature in the software that allows you to calculate the Barrett LF based on the SRKT. And all I did was simply click to highlight and then a right mouse click to populate the option to calculate the Barrett LF constant from the SRKTA. And internally it will calculate that new value. The design factor is the diopter at which any lens might change from a biconvex to a meniscus lens, a biconvex, yes, I was saying that right, to a meniscus lens design. So perhaps at 5 diopters, this lens might change from a biconvex to meniscus. Haag values may be offered by your manufacturer, but typically they're only found on the ULIB for those older lenses. And the Hill RBF can actually be found on Dr. Hill's website. That's rbfcalculator.com. And under lens constants, you'll see published A constants for various lenses there. And Dr. Hill says that if you cannot find an A constant there, you can simply use the same value as your SRKT. The ACD, optical ACD, on the specification sheet for any lens is actually the Hoffer Q PACD value. And the Holiday SF will be the optical SF that you also find on your specification sheet. So once you've entered these values in, the manufacturer A constant should actually be acoustical to better represent that value. The manufacturer A constant is usually the ultrasound A constant that you find on the box, which is typically a smaller value than your optical A constant. Now, if you're measuring with a contact A scan and you're changing your device type to acoustical, you probably should change this to SRKT. That way you can at least get an SRKT calculation when you're obtaining your A scan with contact A scan. All right, Olsen values. These are very difficult to obtain. However, your manufacturer may suggest Olsen values for you as well. Now we're going to click OK, and you will find we can add that new lens by that new manufacturer here in our template. All right, let's go talk about toric. The toric planner feature for the iSuite software came out about 7 years ago. However, we only started including the toric planner for new Lenstar purchases about a year ago. So if you purchased your Lenstar before then, you may not have the toric planner. And in our latest software, we actually now have 5 toric calculators. The Barrett toric calculator, the Abulafia Koch toric calculator, the Olsen toric calculator, a commercial calculator, and now the Barrett TrueK toric calculator, which is also going to have some improvements here in our next version coming out shortly, the i9.5 software. The nice thing about having the toric planner feature is, of course, the elimination of having to transcribe all of your measurement data and surgical preferences into a third-party software and then checking it a million times to make sure they're all right. You can actually view these calculators simultaneously on the same page, and both eyes, in fact. And you can open the surgical planner for any calculator by clicking on the little green icon with the scalpel across. And this is going to open a nice photographic image of the eye with your incision location, which is preset, and steep and flat axis with an IOL overlay. And keeping in mind, this photographic image was taken at the same time as your biometry information. You're also going to notice 3 levels of correction in our latest software. And you can rotate the incision location. It will recalculate your anticipated residual astigmatism, much like those online calculators. Now, notice this patient has about a half a diopter of astigmatism, and it's against the rule of astigmatism. Barrett typically does not flip the axis, so it's saying use that non-toric. And the Abulafia Koch actually will flip the axis, so it's saying use a T3. However, in order to see a flipped axis with the Barrett, click the surgical planner, and there's your flipped axis result. And it's actually agreeing with the Abulafia Koch. With a T3, it's actually predicting approximately 0.14 diopters of with the rule astigmatism. Now, we have discovered that if your toric lenses are entered starting at 0.75 or 0.9 diopters of astigmatism, you won't be able to see a calculation with your Barrett toric calculator. And when you open your surgical planner, you're missing those 3 levels of correction. Unless you add a non-toric model. So in your IOL editor, you find your toric lens. On the manufacturer data tab, you click that plus sign to add a new row. And in this case, we called it SN6 ATX non-toric. And we gave a very minimal amount of the power at the IOL. Then clicking on the calculation tab, we can click the blue plus sign next to our calculation constants and pull that non-toric over into our calculation constants and changing the range from 0 to the first level of correction, so 0 to 0.75 in this case, leaving the power at the cornea at 0. Now, when we do this, we're able to pull in a calculator now for those patients with a small amount of astigmatism. And this also enables us to open the surgical planner and see that flipped axis result. Now, just so you are aware, when you're running toric calculators, if you're doing so for many different surgeons in your practice, these values have to be changed every single time a calculation is run. You may not be aware that your iSuite software can be set up in a multi-user mode, which actually allows you to identify an SIA, incision size, and preferred location for each surgeon. That way, when you're running a new calculation, you simply choose the surgeon and it will automatically apply that surgeon's preferences to their toric calculators. Now, if you're interested in this feature, Carrie and I can assist you with setting this up in your practice. Now, in our latest software, we also have lots of post-refractive formula options. Barrett True-K, the Barrett True-K toric calculator, Shamus no history, Masket, and modified Masket. In the measurement data, now this is after we click the IOL icon to perform a new calculation, we can change a setting here. Usually that says simply US. We can change that to US post-refractive and it will add 2 additional fields here, one for pre-VC or pre-vision correction information and one for post-VC or post-vision correction information. And if we have it, we can enter the patient's refraction before they had LASIK surgery, or PRK or RK, and the 4 to 6 week stable post-operative refraction, and then choose the type of procedure. Now, typically you don't have that information, and maybe you only have one piece of that information. If that's the case, if either of the case, don't enter anything at all. You simply need to select myopic or hyperopic in the pre-VC box, and the type of procedure in the post. Now, clicking on calculation, you will be able to refer to previously saved refractive templates, or we can create new ones. So notice for the right eye where we had the refractive information, we have the option to display Barrett True-K with history, Shamus no history, Masket, and modified Masket. And for the left eye where we did not have the refractive data, we have the Barrett True-K without history and Shamus no history to display. Now, before we move into some Q&A, I just wanted to mention that if you need update to your software to the latest version, contact our tech service department. There will be no charge for the update as long as you have a maintenance agreement. However, if you don't have a maintenance agreement, we just charge a minimal fee of $150, and that's for the entire day if it takes that long. And that's for just the service to update. And if you need a maintenance agreement, or if you're interested in adding the toric planner feature, which is currently at a 10% discount until May 29th, you can contact Tanya Lay. We also have some discounted remote trainings available until May 29th. So if you're interested in signing up, please contact our customer service department. And if you have any clinical questions, you can reach out to either Carrie or myself. And if by chance any of your questions are missed today, just type your email in the chat box and we're going to do our best to reach out to you. Okay, now for some questions.
Okay, so Kirsten, can you hear me?
I can.
Okay. So the first question I have is, should I add the standard retinal thickness value to my immersion A-scan axial length when entering it into the Lenstar?
Interesting question. I'm going to say reach out to your colleagues to find out what others are doing. But I do know that Haag-Streit has mentioned that immersion and optical are so very close that it's acceptable to use those optical A constants when calculating. The bigger difference is that contact A scan when you're indenting the cornea and only measuring to the inner limiting membrane.
Okay, another question is, what if the patient has had RK, then LASIK later, and also enhancements? What do you use for the post-refractive status?
Good luck. Yeah, those are very complicated cases. And again, I'm going to say reach out to your colleagues to find out what they're doing. Yeah.
All right. How do I know if I have the newest Barrett or Hill formulas?
So again, you're going to want to check your software version, and if you go to the toolbar and click on that question mark in About iSuite, that will reveal the software that you're running on. And you really should probably be on the latest version to have all of the latest features and the latest updates to the formulas.
Okay, I have, are there any tools to help with my toric lens alignment intraoperatively?
So as far as microscopes, I'm assuming that question is kind of along the lines of using a microscope.
I would think more just maybe repoint out the surgical planner with the overlays and the angles.
Oh, okay, yes. Yeah, the surgical planner, let me just go back to that and show you some more features there. So in that surgical planner, you also have some options here that to enhance the image. We can equalize and brighten the image. It brings about the scleral vessels, usually a lot of nice landmarks here that we can utilize. And there's also some overlays that we can apply. So the pencil tab here lets you apply some overlays. A pointer, you can point something out, put a circle around something. But what I find most useful is this angle icon. So if you can find a couple landmarks to point out, you can also identify how many degrees from 0 any landmark resides. So this is kind of helpful in identifying a good position for the lens and where the center haptics might line up.
Perfect. I know we did have a question early on about moving our gates and if it has to be with multiple colors or if it could be a single spike. And I did emphasize the point of multiple colors. I don't know if you want to show that again.
Yeah, so multiple colors is recommended, but a bilateral comparison is telling too. So that's a nice way to validate those interesting spikes and if they're weak or if they're only one single color.
Okay, I'm seeing if we have more here. Oh, Q&A, okay. So for the post-refractive calculator, the fill was in plus. Can you insert in minus or plus?
Yes, you can change that in the settings, certainly. And I can actually walk you through that. Let's see. Tools, preferences, general, anatomy units. There it is, minus fill, plus fill. So if you want to, whoever asked that question, if you want to use your phone and take a screenshot of that, that's just the tools and preferences under the general anatomy units. And there's your option to change from minus to plus.
Okay, so why are there cautions noted after calculations are run in the various lens templates?
Oh, yes, thank you. I forgot to go over that. So if you are running, let me go to actually, that happens on this measurement with Hill. So you will notice cautions next to Hill calculations anytime those calculations are questioned, because the Hill RBF calculations have an internal validation guide. And what this caution means is that the calculations are out of bounds, and Hill actually recommends not using any lens power that has a caution next to it. Instead, he recommends using the Barrett or the Olsen. And it's simply because the Hill RBF method is based on actual cases. And so if the measurements that we took are different from all of the cases he's used for this method of calculating, then it gives it a lower confidence rating. He just hasn't included enough axial length of 18.23.
Okay. Would there be any additional or different steps to add the PanOptix trifocal lens to our lens list?
So I'm going to make this really super easy. We have lens files that we can easily transfer into your database. So if you need help adding the PanOptix, we can do it quite simply. In the IOL editor, there is an option to import and export lens files. If you are computer savvy, we can even email you the lens file, and you can do this yourself.
Can we find out ICL lens position by axial length graphs?
Can you repeat that?
Can we find out ICL lens position by the histogram?
So I'm not sure exactly. I know what that question means as far as position. You can certainly, this is not always this nice of an A scan, but you can get an idea, how far in that ICL is and how thick it is. But the true function here is just to obtain the true phakic ACD and lens thickness measurements that is required by those newer generation formulas.
Mm-hmm. If there are no caution markers on the IOL calculation sheet, is there still a need to review the biometry readings? The only thing that I would look at, I would do a bilateral comparison just to be sure that everything makes sense, and check the standard deviations, because there's no internal flag as of yet on high standard deviations for axial length in case. So always check standard deviations for those most important values. And if there's no cautions and everything looks like it makes sense bilaterally, then no need to review. And sometimes that's the case. Sometimes a scan, a lot of times you can take a scan with a Lenstar and nothing needs changed. Can we check angle kappa?
So it's not actually angle kappa. but it's an idea of angle kappa in the pupil barycenter. Now, I will tell you that Emory Eye, this is what they do. They take their average X and Y values, add them together regardless of the sign. So adding this together, help me out. 0.39 plus 0.28 0.67. So Emory Eye says a 0.6 above 0.6 would be a bad candidate for a multifocal lens. So 0.67 would disqualify this patient from a multifocal. Haag-Streit documentation indicates that 0.4 in any direction would disqualify a patient for a multifocal.
Going back to that question about the lens spike, the person typing, they advised that whoever had trained them indicated that it had to be at the very last spike regardless of multiple spikes. Sorry, was that for the lens spike? Yes.
Yes, and you know, that's a really, really good rule of thumb to always make sure gates fall on the very first and the very last spike of multiple colors. I just want to caution you, if you ever measure that ICL patient, you may want to look at the A-scan just to confirm you're not accidentally picking up on that implant lens and falsely making your lens thickness too thick and your ACD too shallow. Now, on that patient that I showed you, I ran calculations before and after, and it really only just shifted the intended refraction. And depending on how much those gates move, if they're moved more, then it's going to affect the calculation more.
Okay, well, Kirsten, I think that about sums up our questions, and we're at our time limit here. I bet people want to enjoy their evening.
Thanks for your help, Carrie.
Yeah.
Yeah, let's go have some dinner. Thank you, everyone, for joining.
Okay, thank you, everybody. Have a great night.
Yes, thank you. Thank you, everyone.